Now, it is very important to know what is the cause of fall, what makes it a patient with fall, because why is it important? If the patient is at increased risk of fall, it's going to, if sometimes some patients has a fall, then it's going to lead a permanent immobility, and immobility is going to lead a lot of other issues related to bed bound strategy. So that's very important to prevent this fall from happening. How are we going to do that? We'll see that. Number first thing that we discuss as a tool is get up and go test. All right. If you see here, so this first thing is requirements for safe ambulation. So that's very important. So while you are assessing a patient and you want to make sure that the patient is not at risk of fall, you need to assess for the safe environment. The patient is not a safe environment means that there are no slopes where he's living, he's coming back and going back. So the environment is generally safe. There should be good vision of the patient, and freedom from neurological deficits and vestibular dysfunctions. These are the things that may lead towards fall. Healthy musculoskeletal system is going to decrease the risk of fall. A good cardiovascular status and the good cognition is the key if you want to decrease the risk of fall. Assessments. So we talked about the get up and go test. In the get up and go test, you're not just timing the patient's get up and go strategy, but you are also interested in the gait, if there is unsteadiness on there or not, and maybe the patient has some knee pains because of the osteoarthritis and things and like that. So there are a lot of information you can get when you ask the patient to walk. The second thing is there any cerebellar dysfunctions? And you need to also check for the cerebellar signs in order to see whether the patient is at increased risk of fall or not. The third thing is the postural drop. That's very important because of the physiology that, as we discussed, the postural drop. What is the postural drop? You take the blood pressure on the sitting position, you ask the patient to stand up and then wait for maybe 10 seconds, and then you repeat the blood pressure. So after repeating the blood pressure, there is a drop in the from 10 to 20 mmHg. This is called postural drop. So if this is present, these kind of patients are also at risk of developing fall. So if you see here, the gait, you see if there is unable to stand without use of the hands, may because of myopathies, may because of deconditioning, may because of knee or hip joint pain. If you see there is an unsteadiness, that the patient is very unsteady, he may have some balance disorders. If you see the gait as small short steps, it is because of the Parkinsonism. If the patient has wide base gait, this is because of the cerebellar disorder or fear of fall. These are all clinical manifestations, or you can see the clinical findings in the gait. If there is asymmetry, then there is some focal problem is there. If you see that the patient has flexed knees, it's because of the contractures and quadriceps weaknesses. If you see that if you observe that there's very slow gait, and maybe because of the fear, maybe because of some weakness, maybe because of some chronic illnesses. So how are you going to decrease the risk of fall? That's our objective, not not to manage the condition after the fall, but our job and main function is to decrease the risk of developing fall. Once the fall happens, the whole cascade is going to begin. The patient is going to get bed bound. There are multiple bed sores. There are multiple comorbids that are there. That's going to complicate the situation. So the first and the foremost thing is reviewing the medications. Maybe the patient is on tricyclic antidepressants. Maybe the patient is on benzodiazepines. If the patient is on antihistamines, if the patient is on antihypertensives, you need to assess all these medications, review these medications. Why? TCAs having unsteadiness, benzodiazepines also contribute toward consciousness, antihistamines because of the drowsiness, antihypertensives because of the postural drop. So that you need to see the maybe you need to address, or you need to decrease the doses, or you may want to decrease the doses as required, or omit some of the medications if it is required. The second thing is postural hypotension. How are you going to do it? Elevation of the head end of the bed and use of handrails while getting up. So this is what you're going to what you're going to tell to the patient or counsel the patient who has postural hypotension. If the patient, if you see there is gait disorders, then obviously you need to give some assistive devices, some strengthening and balancing exercises that are going to help in the patient not to develop fall. Impairment in the legs and the arms and the range of motions, so you need to give some resistance exercises to the patient, educate them about that, so that it can decrease the risk of fall. Vitamin D supplementations are also very important because of the muscle weakness, and some hip protectors if required. Now, the second aspect is the environment. So, not just the patient or the person as a whole, but you also need to assess the environment. What about the lighting? Maybe the patient does not have a sufficient light at night and he falls because of that. He may fall because of that. Maybe there are a lot of obstacles in the way to the washroom in the night. So that's going to also give patient a very hard time. So you also need to assess some environmental factors. One is the good lighting. Second is the handrails. That means that when the patient is going to the washroom, make sure that you have some support system, extra support system within the washrooms, because there are a lot of falls which occurs within the washrooms because the patient got slip up because of the slipping of the floor, a patient falls down. So handrails are very important in the washrooms particularly, and also use bathroom mats in order to avoid slippery floors. What complications? What if fall happens? What is going to happen? Number one is fractures. Obviously, they may have subdural hematomas. They may develop dehydration, electrolyte imbalance, pressure sources, fear of falling, and immobility. These are all the complications of fall. So in fall, the proper history taking and the proper the proper assessment of the gait and the proper support with the environmental risks evaluation is very important in developing the patient who has fall. So let's discuss this dementia. We have talked about dementia.
Doctor,
The medication lists are very important. So the
doctor,
yes, yes, please.
doctor, I have a question regarding the
Yes,
falling.
yes, yes.
Regarding the geriatric group, I heard before that for any patient of geriatric, we are suspecting, for example, falling on the hip. We should do MRI to exclude the neck, the fracture of neck of femur. Is that applicable in the real life? I mean, we should do this in clinical life, or it is just for in books?
If the patient has a fall, then obviously you need to see what is the damage happen. If you think
Mhm.
that the patient has maybe you're suspecting hip fracture, because it is very common, then you should have an x-ray. X-ray can also tell, simply the x-ray can also tell, not to do the MRI directly.
Yeah, but because the science comes on X-ray very late after the necrosis happens, so this is why I'm asking about this.
They usually do not do MRIs so frequently for hip fractures.
Mhm.
If it is a fracture, it's going to come immediately. It depends on what kind of fracture is there. That's the problem. If there's a neck of femur fracture, you may find it out in the chest X-ray, on the X-rays. But
Oh,
if you think that your clinical suspicion is high and the X-rays are going to be normal, then obviously MRI is the thing, is then the thing. You don't do it MRI firstly for all
oh,
patients who you suspect.
yes, doctor. Thank you. Thank you very
Okay.
much.
So any other question regarding the fall?
Yes, doctor.
Yes, please.
Doctor, you mentioned postural drop and